Well, good afternoon, everyone. We are at 3 minutes after and want to respect your time, so we're going to go ahead and get started. And I am going to begin our video recording as well. My name is Alex Huffman. I am the Assistant Director of Support Services here at the Cancer Center, and am very excited to welcome you. And thank you for taking time away from your busy Fridays to lunch and learn with us. We are doing this as a part of National Cancer Survivors Month, the month of June. And just a quick introduction on that. The National Cancer Institute defines a survivor as anyone living with a cancer diagnosis. So from the time of diagnosis and beyond, you join a community of 18 million Americans living with cancer right now. This month in June is set to celebrate everyone and to connect as a community. We also want to celebrate the milestone and advances that have happened in cancer research and treatment. And immunotherapy is absolutely one of those. From standard of care for some diagnoses at this point to a treatment that's being studied in numerous clinical trials. Today we are going to learn much more about immunotherapy from Dr. Isaac Chan. So I will, in just a second, turn it over to him to give his presentation. I did want to make just a few notes. One, you are all coming in on mute, so we are not going to be able to hear from you directly any questions or comments you might have. We do have a great feature at the bottom of your screen so that you can submit your questions, and Dr. Chan will do his very best to try to answer those. To that point, Dr. Chan is not able to answer personal questions on any treatments or decision-making related to diagnosis and specifics in that way. So please keep your questions general, and hopefully we can all learn from each other there. And again, this is being recorded and will be available on the Cancer Center's YouTube page after this session today. So I'm going to turn it over to Dr. Chan. And Dr. Chan, thank you for stepping away from clinics and research labs to present immunotherapy today.
Hi, thank you so much, Alex, for that really great introduction. Let me try to start sharing my screen with you guys, and maybe we can go ahead and get started. Is it showing up right now?
Not as of yet.
Okay. Do this. How about now? Everything's coming up.
Yes, we can see it now.
Okay.
We sure can. Thanks.
Okay, great. My name is Isaac Chan. I'm a physician scientist here at UT Southwestern. I'm a medical oncologist, and I see patients with breast cancer. But my training, when I was training at Johns Hopkins University, was in immunotherapy. And so this is a topic that I'm very passionate about. My research is in immunotherapy, and I'm very excited about the directions where we can use immunotherapy to improve patient lives and extend patient lives that are affected by cancer. I'm very happy to answer questions. And I think, Alex, you said we have a Q&A session at the end of this talk. And so I'm just really excited for that because, I want it to be at least as interactive as we can make it instead of making it just a pure lecture style. I don't have any disclosures to talk about. So the outline of today's talk, I just wanted to first introduce kind of the pillars of medical oncology. What do medical oncologists use in terms of treatments, medicines that we can give to people to help treat their cancer? Then I'll talk a little bit about how our body's immune system is actually really good at controlling cancer. Then we'll get a little bit into what is immunotherapy. We'll start to define that. We'll go over some current immunotherapies. We'll take a little bit of a historical detour to tell sort of the history of immunotherapy and when did this all start. We'll talk about some of the patient questions that often come up when we discuss immunotherapy in the treatment setting. And that's really centered around what are the side effects? How will this impact my everyday living? And then finally, I think one of the exciting things that we're really, my lab is a big participant in is helping to shape the future of immunotherapy. And we'll talk a little bit about where we think the field can go. So before kind of 2011, I say 2011 because that's really when one of the first immune checkpoints or immunotherapies, common immunotherapies, was FDA approved. Medical oncologists really had two types of medicines that we could deliver. And one of them's chemotherapy, and another pillar of that type of medicines that we could deliver was targeted therapy. And so chemotherapy really targets specific cancer cells that are growing very rapidly. So cancer cells, cells are the building blocks of our body. Cancer cells are the building blocks of a tumor. And so you usually can start from a few cancer cells, they grow and divide into more cancer cells, and eventually they divide and grow into many cancer cells, and that becomes a tumor that a physician or a patient might feel on their body, or a physician might detect on imaging scans that we do. And what chemotherapy does is actually targets rapidly growing cancer cells. So cancer cells that are quickly splitting into one or two and growing and dividing. The chemotherapy actually kills these rapidly growing cancer cells. And so as an aside, there's other normal cells in your body like hair cells or gut cells that grow at a similar rate. And so that's why chemotherapy can't really discriminate between those cells and cancer cells. And that's why some patients might experience side effects from chemotherapy like hair loss or nausea. The other tool, the other pillar that medical oncologists had, the other medicines medical oncologists had to use to treat cancer was targeted therapy. And that's often when we can use cancer cell specific features, and those features are often described to you as, and we often talk about those terms as mutations, but really it's just cancer cell features that we base our drugs on. And so, for example, if there's a purple cancer cell or a blue cancer cell or an orange cancer cell, we would deliver a purple drug or a blue drug or an orange drug. And obviously that's a very, very, very simplified model, but that's the gist of what targeted therapy is. We would pick one specific feature on the cancer cell and we develop a drug that can be used to exploit that cancer cell's feature and kill the cancer cell. And so basically what we were trying to do is match the correct drug with the cancer cell feature. But after a lot of research, immunotherapy has become an exciting new pillar of tools and medicines that medical oncologists can use and oncologists in general can use to treat patients with cancer. And it's really spurred a revolution. And I'll tell you in a few slides why this has been so exciting for people, for oncologists and for patients, because we're able to see very long-lasting responses to our therapies, where we really haven't seen this type of response before. And so here you can see, and you might have heard about this or read about this, on the radio, heard about it on the radio, or read about it in newspapers, or seen on TV. This is from the New York Times. This is a headline saying, we're harnessing our immune system to fight cancer. And, another very reputable magazine, Science magazine, called it the breakthrough of the year, cancer immunotherapy, T cells on the attack. And so exactly, what is immunotherapy? Well, immunotherapy is using our body's own immune system to control cancer better. And our bodies actually do a really good job of controlling cancer naturally. And so one of the reasons I know this is because all of us, Alex and I just talked about how hot Dallas was going to get But all of us step out into this hot sun and the sun hits our face, and we all hear about the sun damage. So when the sun hits our face, it actually can damage some of the cells or the building blocks of our skin. And sometimes that damage can lead to cancer, but a lot of times it doesn't. And in fact, most times it doesn't. And that's because our body has a really good way of detecting any of those cells that might become cancerous. And that's through our immune system. And so there's a framework that scientists have kind of talked about how our immune system can control cancer. And what happens is you might have cancer cells that die. So you might start here in the cycle. Cancer cells that start to die for whatever reason. And when they die, they release information out into the body that suggests the type of cancer cell they are, that they're present. And your immune cells, your body's immune cells actually recognize that information from the cancer cell death. And they go and talk to other immune cells. So they gossip to each other. And they go and they use that information. They say, this information that I have here tells us that there's a cancer cell in our body. We have to go and get rid of it because that's not normal. That's not good to have. So they tell everyone. They tell all the other immune cells. And there are specific immune cells that actually hunt cancer cells. Those are the cancer-killing immune cells. And they actually can go and take that information and say, well, now we have that information. We're going to go and find those cancer cells and hunt them down and kill them. And so that's what happens. Those cancer-killing immune cells go to where the cancer cells are and they kill them. And that actually starts the cycle all over again, because then those cancer cells die and they release information when they die. And then other immune cells recognize that information, take that back to the collection of immune cells. And that's how the process continues in a feed forward manner. And so this is a very effective system at controlling cancer. So I think we talked about how our immune system is really good at controlling cancer cells. Here's a blue immune cell and it's killing this cancer cell here. But unfortunately, when cancer does develop, our immune system eventually stops controlling that cancer. And so what happens then? Well, once it stops controlling that cancer, then it starts a process where the cancer cells can multiply and they can grow. And so what happens at that point is that the cancer cells get really smart. And so what they start to do is they start to communicate with the immune cells as they get bigger and as they grow and divide. They actually send stop signals to the immune cells. And they say, don't kill us anymore. We're big, we're here, it's not your job anymore, don't kill us. And so actually the cancer cells start to trick the immune system into not killing them. And so that's bad. And so what we learned is that there's this intricate communication between cancer cells and our own immune system that stops immune cells from killing those cancer cells. And once we figured out what those signals were, we were able to develop drugs to stop that communication. And that's what immunotherapy essentially is. That's the condensed concept of immunotherapy. Is that immunotherapy, especially one of the biggest categories and the most used immunotherapy currently on the market, is used to remove the stop signal. And once immunotherapy is able to remove the stop signal, the immune cells can once again kill the cancer cell. And so essentially, current immunotherapy helps the immune cells to remember again what it was like to kill the cancer cells, and they remember how to do it. And The most common immunotherapies that we use are called immune checkpoint inhibitors. This is the most common class or the most common category of immunotherapies. Most of our immunotherapies focus on activating or helping a specific immune cell called a T cell. So one component of the immune system, these T cells, is one of the main components. And most immunotherapies are focused on helping it remember to kill cancer cells again. And when we talk about a term like immune memory or memory, what we're trying to go for is a long-lasting tumor-killing response. Because the immune cells, as part of our immune system, aren't just a one-time event and then stop. It continues to circulate through our body. Immune cells continue to circulate through our body and continue to be actively surveilling against cancer cells. And once it remembers how to kill the cancer cells again, it can go throughout our body and seek out those cancer cells, like I mentioned in a couple slides ago. Those cancer hunting immune cells, they go throughout the body and remember how to kill the cancer cells again. And that's what's leading, and that's what's creating a lot of hope around these long-lasting tumor-killing responses. And so, like I mentioned, immunotherapy is so exciting to us because of these durable responses or these long-lasting responses that we're able to generate by treating patients with immunotherapy. And so this is one of the first trials using immune checkpoint inhibitors called ipilimumab in patients with metastatic melanoma. And so patients with metastatic melanoma, before when we used chemotherapies to treat it, it had a very, very poor prognosis. And so this graph here that you're seeing is called a Kaplan-Meier survival plot. And so I'll go through with everyone how we might interpret a graph like this in case you happen to see one of these graphs again. And so on the y-axis here is a percentage. So this is 100% and this is 0%. And the words here say overall survival in percent. And basically it's capturing how many patients that are measured in this clinical trial, how many of them are living at the time of measurement. And so that's captured here on the x-axis in terms of months. So the time is in months. And so to interpret this, you look here and you say, well, at time 0, when we started measuring how well patients were doing in this clinical trial, there were 100% of patients living. But for this group of patients, they did not receive immunotherapy. And so as time goes on, so when we're at 12 months, the way we read this graph is that probably around 30% of patients were alive at the end of 12 months. So a very sobering statistic. However, when patients received immunotherapy, and that's designated in these lines here, at 12 months, over 40%, close to 50% of patients were still living who had received immunotherapy. And so when this data came out and when people were involved in the trial, I knew some of them. They were very excited about this data because suddenly we were seeing responses in patients that we had never seen before, especially for a disease like metastatic melanoma. And when they concluded the study, they were even more excited because there were some patients, even though the percentage of patients overall had dropped in terms of their survival, there were some patients that remained alive for a very long time. And so it turned metastatic melanoma from a disease where we really had no effective treatment for into a disease where we could use immunotherapy to give patients hope about a potential treatment. We saw the same response across different cancers like lung cancer. This was done when I was at Hopkins. This was a study both studies were out of Hopkins, but here we had patients treated with immunotherapy in the blue line here with nivolumab, and then the green line with chemotherapy. And you can start to interpret the difference. At 12 months, 42% of patients were alive when they were treated with immunotherapy, and 24% of patients were alive when treated with chemotherapy at 12 months. And so there's a very dramatic difference when patients were being treated with immunotherapy. I'm showing a lot of graphs today, so I apologize if that's disrupting your lunch, but hopefully I'll walk through the second graph and that'll be it. This is called a waterfall plot. So the previous graph I showed you, that's called a Kaplan-Meier graph. Here, this is called a waterfall graph because it looks like a waterfall. And the interpretations of this graph is that on the y-axis, there's this very long sentence here. It says change from baseline in the sum of the longest diameters percentage. So some mumbo jumbo there. But what it really means is they're measuring how big each person's tumor was. And so if you kind of interpret what that sentence was, it means, you know, on the y-axis is measuring how big did the cancer grow? How big was the tumor? Was it, did it grow big or did it shrink? And so what they're measuring in each column represents a patient and the measurement of the patient's, the tumor growing in the patient. And the blue and black colors over here are specific cancer cell features. And so this was one of the first trials that actually matched immunotherapy to specific cancer cell features. So I think at the very beginning of this talk, when we began, we talked about targeted therapy and how we can match drugs to specific cancer cell features. Well, here we're starting to be able to match immunotherapies, immunotherapies to specific cancer cell features. And so when we found patients that had cancer cell features thought to respond to immunotherapy, they did a lot better, and their cancers actually shrunk. And so this was very exciting because this population was this group of patients had very difficult to treat cancers, and we were seeing very dramatic responses in terms of cancer, in terms of tumor shrinkage. And so again, adding to the excitement of why immunotherapy. And so I'll just round out this section by just mentioning that there are different categories of immunotherapy. So I spoke a little bit about the mechanism of immune checkpoint inhibitors. So this one of our most commonly used immunotherapies that are FDA approved, and that's removing the stop signal from the cancer cells. And the names of some of those common immune checkpoint inhibitors are pembrolizumab and nivolumab, and there are others. Some treatments have focused on removing the stop signal from other immune cells. Some treatments work on stimulating immune cells to go towards the cancer cells. Those are sometimes grouped as tumor vaccines. We heard a lot about vaccines. And so you're going to start hearing a little bit more about what tumor vaccines might be. And then other categories of immunotherapy focus on giving back immune cells, whether that's someone's own immune cells or whether that involves taking immune cells out of a person, engineering them and putting them back in to a person. And that sometimes is mentioned in the media as CAR T cell therapy or CAR NK cell therapy. And I'll talk a little bit about my lab's roadmap for developing NK cell therapy. Here at UT Southwestern, we've been really pioneering really innovative alternative therapies that strengthen immunotherapy. So here, this is a trial that's led by Dr. Heather MacArthur. It's a phase 2 trial. She's our internationally recognized leader in the breast group. And I'm very glad that I could be part of this trial because it's a really neat trial where if you look at this patient's tumor, and it's outlined here in yellow, you can see it's this big white tumor. What the innovative part of this trial is that they actually use cryoablation, or they essentially freeze the tumor while it's in the person, and they create this giant ice ball inside the body. And the thought is, and there's some preclinical work or some laboratory work that supports this approach, is that when you freeze the tumors, you can actually stimulate our immune system to remember how to kill cancer cells again. And so the result of freezing this tumor resulted in a much smaller tumor that was then surgically removed. So that's a very exciting trial that we have going on. So just to kind of go back to why is immunotherapy so exciting, I'm sure many of you know Jimmy Carter, our former president, but I'm not sure how many of you knew that he actually has metastatic melanoma. So his melanoma actually spread to his liver and brain. So he has stage 4 cancer. And that used to be a death sentence. He was diagnosed with metastatic stage 4 melanoma in 2015. He was treated with immunotherapy, and he's still living today. I think recently the news came out that he had entered hospice, but he had, since 2015 to 2023, he had 8 more years of living with melanoma. I have my own amazing success stories. So, I was witness to patients that I treated with metastatic cholangiocarcinoma. Again, a very, very hard and difficult to treat cancer. My patient had a 10-centimeter lesion in her liver. I treated her with immunotherapy, and she remained alive for 5 years. She was 75. She eventually passed when she was 80. She saw her daughter get married. She saw 2 grandchildren go to college. She attended countless baseball games. One of her grandchildren was a baseball star in high school. And she had 5 more Christmases. Christmas was one of her favorite holidays. And she got to experience 5 more Christmases with her family. And so that's a tremendous success story when we can use immunotherapy to really help people. And so that's why the whole field is very excited about immunotherapy. But that took a long time to get there. I wanted to delve in just a little bit about the history of immunotherapy, because we often see the end result, which is the drug, but that drug was based on decades or centuries of scientific progress. And science is very iterative and often can take a long time to turn discoveries into medicine. And so this is William Coley. He's credited to as being one of the first physicians to use immunotherapy. So what he did was he actually did something kind of out of the box thinking. He saw a patient that had cancer and had a skin infection. And every time that patient got a new skin infection, their cancer shrunk a little bit. And so that got him thinking, if we can stimulate the immune system to maybe target cancer, is that a way for us to treat cancer better? And so he developed this concoction of Coley's toxins, which he essentially took dead bacterial cells. He took someone's infection, killed the bacteria, and then injected it into a patient's cancer. And this was a New York Times article in July 29th of 1908. This is the headline. Dr. Coley's remedy of mixed toxins makes one disease cast out the other. Injecting, bacteria into someone's cancer and then seeing the immune system try to clear that cancer, get rid of that cancer. And so he was credited for the first use of immunotherapy. That didn't end up being standard of care, but it did launch a lot of research on how we can use our immune system as an effective medicine. So this, I mentioned this ipilimumab, which is our first approved immune checkpoint inhibitor. It was actually the target of the drug was first discovered in 1987. Jim Allison, one of the pioneers of immunotherapy, he won the Nobel Prize. His seminal discovery, or the experiment that kind of put immunotherapy on the map here, was in 1995. And then we got FDA approval in 2011. So that was 24 years from the time of discovering a potential target for a drug to the FDA approval. And so science is iterative, and it really does take a long time to turn discoveries into medicines. And so we're really trying to focus on how do we accelerate that timeline. So immunotherapy is great. I talked to you guys about all the successes of immunotherapy, but what's the catch? And so sometimes when we remove the stop signal for immune cells to kill cancer cells, we can also remove the stop signal for normal healthy cells as well. And so some of the side effects that people might experience with immunotherapy mirror autoimmune disease, because you've essentially taken away the stop sign for the healthy normal cells. And so the immune cells could target those healthy cells. And so a lot of different areas of the body could be affected by immunotherapy. In the skin, people could experience rashes. In the gastrointestinal tract, people might get diarrhea. They might have liver injury. They might have thyroid involvement. The kidneys can be affected. The lungs could be affected and will sometimes show up as a cough or very severe cough or difficulty with the lung function. Joints can be affected and can manifest as arthritis. Blood cells can be affected. Heart cells, the heart can be affected, and you can get inflammation of the heart. And nerve cells can also be affected. But I just want to add that a lot of these side effects are very rare. They don't often occur in patients treated with immunotherapy. And I think that's worth a discussion with your physician about what some of those side effects might be. But does that mean that patients with autoimmune disease cannot receive immunotherapy? The answer is, at the beginning, when we were first using immunotherapy, we were very cautious. And so we wouldn't allow patients that had autoimmune disease to receive immunotherapy. But here at UT Southwestern, we're really leading the way about how we use immunotherapy. So this is a clinical trial led by Dr. Hans Hammers, actually looking at this question. In patients with a history of autoimmune disease, can we give immunotherapy? Is it safe? And that would really open up, if we were to ask and answer this question, it would really open up immunotherapy for another subset of patients to could benefit from it. And so we're really leading the way and having a lot of these different and unique trials here at UT Southwestern. But unfortunately, despite all our best efforts, immunotherapy doesn't always work for everyone. In fact, 60 to 80% of patients do not benefit from immunotherapy, including those with breast, prostate, pancreatic, and testicular cancers. And so we're really trying to figure out on the research end, why is this the case? And what I believe, and what my lab believes, and what others believe, is that we can develop immunotherapies that work for everyone. And so that's what my lab is trying to do. We think that immunotherapy should work for everyone, and we're trying to figure out how do we get there. And just as an aside about who I am, I'm a physician scientist. And so that means I treat patients with cancer. I treat patients with breast cancer here at UT Southwestern. I also run a lab at UT Southwestern, the Chan Lab. And I perform what's called bedside to bench to bedside research. And so that means what inspires me as a physician scientist is that patients inspire me as a physician scientist. And I try to identify issues in the clinic that we can try to answer in the lab. And then I take those findings and those clinical solutions that we identify in the lab, and I try to bring them back into the clinic so that we can help patients there. And so our focus is actually, of my lab, is actually developing new immunotherapies. And so the current immunotherapy is really only focused on one immune component. So I mentioned this in previous slides, but current immunotherapy is only focused on T cells. So it's a main component of the immune system, but there's many other components of the immune system, as you can see on this slide. And so one of the components, or one cell type that we have deep expertise in, we've made significant discoveries about the biology of this cell, is called the natural killer cell. And so our lab has started to use other immune cells as a way to develop new immunotherapies to control cancer better. And one of our foundational technologies is using mini tumors that we pioneered, this model that we pioneered to use mini tumors donated from patient samples to create more accurate models of someone's tumor. And so what we can do is just take this mini tumor and we can study it under microscope, study it in my lab, and we can see how that mini tumor behaves, how it can grow and spread, and we can observe that type of behavior, bad behavior, I might add. And so what we've done is created a platform that allows us to use natural killer cells, and that's the small dots that you see in this movie. We were able to use natural killer cells to really restrict the ability of that mini tumor to grow and spread. And so we've been able to then use this platform to identify new drugs and new ways that we can use natural killer cells to prevent that growth and spread. I just wanted to show off more movies that we have. But here, you can see NK cells are in purple and cancer cells are in green. And you can actually see how our platform can capture interactions between those natural killer cells and cancer cells. I'll zoom in again on that interaction there. And you can see that we have the ability to capture in a three-dimensional space the natural killer cells in purple and the cancer cells in green. And so we're very proud of the technologies that we bring to bear to identify how we can use natural killer cells to kill cancer cells. But as we develop these new immunotherapies, we're also very interested in improving their accuracy. And so part of the ways that we can improve immunotherapy accuracy is by making sure that we deliver immunotherapy to the right patient. And so one of the ways that we've started to test these methods is by using breast cancer and by understanding how we can treat breast cancer better with immunotherapy. And so breast cancer is actually traditionally classified and treated as one of three different types. So historically, breast cancer is diagnosed as one of three different types. And that three types is the hormone receptor type, this HER2 type, and this third category called triple negative type. And what we discovered was actually one breast tumor contains many more types than just one of those three traditional types. It actually contains 10 types. And what we've been able to do is break down the tumor and isolate each one of these types. And by doing so, we can then determine how much of each type of breast cancer is within a person's tumor. So instead of traditional definitions of breast cancer, we can now classify their tumor using a more high resolution of the different types. And then we measure our body's immune response to each one of those types. And so this means that we can actually determine how our immune system responds to the different types of breast cancer. And by doing this, we can define a person's breast cancer by their immune response. And so by doing that, we can then use that information to create individualized immunotherapies to activate a person's immune system and treat their specific cancer type, and matching the drugs that we develop specifically to that person's immune response. And so with that, I'd like to thank everyone for their attention, for just taking time out of your day to have lunch, to hear about some of the exciting work that we're doing here in terms of the immunotherapy space, and in terms of developing new immunotherapies, and to learn a little bit more about immunotherapies that we use in the clinic today. So just want to thank everyone. And this is our lab website in case you're interested in learning more. And so Alex, I think I can stop sharing right now, and then we can go to a Q&A session.
Great. We have 2 questions already in, and we'll go ahead and invite everyone who may be sitting on a question to put that in the chat or the Q&A feature at the bottom of your page. We can get them either way. So the first question that came in is there immunotherapy being used for glioblastomas right now?
Yeah, they're trying to develop new immunotherapies for glioblastomas. Some of the immune checkpoint therapies hasn't really translated into use for glioblastoma, but they're trying some other different types of immunotherapy approaches.
Great. And the next question is similar in that are immunotherapies being used for chronic lymphocytic leukemia right now, CLL? Yeah,
so there's a lot of therapies in the what they call blood cancer space, where they're trying to add back engineered immune cells to specifically target these cancerous blood cells. And so that's been an exciting area where those therapies have been most effective, is in that sort of blood cancer space.
Great. This question is related to drug shortages. With the national shortage of cancer drugs, is there an opportunity to shift impacted patients to immunotherapy?
Yeah, that's very appealing. I think, one of the foundations of cancer research and clinical care of cancer patients is that we're very evidence driven. And so a lot of the work, when we talk about iteration, a lot of both the laboratory work and the clinical trial work take some time to develop. And so it might be appealing to just kind of try immunotherapy for one person or just try one-off therapies, but that might not lead to a result that we can understand, and it might not lead to any result at all. And so that's why we try to balance some of that caution with some of the acceleration of the advancement of therapeutics. But that's a good question. I don't see that happening though.
So this question is, can you explain why immunotherapies are only used for metastatic cancers at this point?
Yeah, so immunotherapies actually are used beyond metastatic cancers now. They've been used in sort of the adjuvant setting. So that's a setting of treatment where someone already received surgery for their cancer. In breast cancer, for example, they have a immunotherapy approved where we can give it before surgery even. And so I think that's one of the exciting things, exciting movements in immunotherapy research is when can we give it? And it seems like we're not restricted to just the stage 4 setting anymore.
Okay, so a couple more coming in, so I'm going to scroll back up. Can you talk about the use of immunotherapies in lung cancer diagnoses right now?
Yeah, so immunotherapies play a big role in lung cancer diagnosis, in lung cancer, in the treatment of lung cancer. I'd be happy to talk more about it, but the immunotherapy is approved in the metastatic setting, in the adjuvant setting. They're testing it in the neoadjuvant setting. they're testing across different types of lung cancer, like non-small cell lung cancer and small cell lung cancer. And within non-small cell lung cancer, adenocarcinomas versus squamous cell carcinomas. So there's a broad use of immunotherapy in the treatment of lung cancer, and it's shown to be quite effective.
Okay, and the same participant put in an additional note about durvalumab for lung cancer after chemo and radiation.
Yes. I guess that yes, they do use it for lung cancer after chemo and radiation.
Okay. Let's see. This one is.
I guess I was confused about the question, but yeah, I guess that's
yeah,
what
I think it was more of an add-on statement or add-on for details.
Oh, got it.
Can immunotherapy be used after a bilateral mastectomy for ER positive and HER2 positive therapies when all cancer was removed versus doing hormone and targeted therapies for 5 years?
Yeah, that's a really good question, and that's a space that I'm very passionate about trying to understand. So right now, immunotherapy isn't approved for ER positive type of breast cancer, or I guess the other was HER2 positive as well. So it has not been approved for triple positive breast cancer. It's only been approved for triple negative breast cancer and in very specific settings. And so, that's one area of research where there's a great need, is trying to figure out why immunotherapy hasn't been effective for ER positive breast cancers, or as effective.
What determines if immunotherapy will be offered? The individual who submitted this mentioned a triple negative diagnosis and was not offered immunotherapy. How do providers make that decision, Dr. Chan?
Yeah, so that's a really good question. So we do some testing. What we call biomarkers. So that's essentially a cancer feature that we can look at under the microscope. And based on whether there's a specific marker or not, is often used as a trigger for whether or not we can give immunotherapy or not. The other reasons we may or may not give immunotherapy is the cancer type itself. Oftentimes especially in the past decade, there has been many times where immunotherapy has been tried in a variety of cancers. And in some cancers, like ER positive breast cancer, patients have not seen any different responses when using immunotherapy. So it didn't lead to an improvement of outcomes. And so because of that, then we just don't offer it to specific cancers. So it's a mix of the cancer type and also cancer cell features that we might be able to see and test under the microscope.
Got it. Let's see, we've got a couple other questions about additional diagnoses where immunotherapy may be being used. Is it shown to be effective in both leukemia and lymphomas right now in the blood cancer world?
Yeah. So there are a lot different trials ongoing in terms of the use of immunotherapy in leukemias and lymphomas. Immune checkpoint inhibitors have been used to treat those specific cancers. CAR T cells and CAR NK cells have been really exciting developments in that space, especially in lymphomas. And so people have been excited about using that type of immunotherapy to treat lymphomas and leukemias.
Great. And then additional questions. How about use in intraductal carcinomas and prostate cancer? Are we seeing immunotherapies there?
Yeah, in prostate cancer, has not been as much movement. They were one of the first cancer types to use the transfer of T cells back into someone. So I talked about giving back immune cells. So taking someone's immune cells out of their body, modifying them and putting them back in. So that in that cancer specifically, there's a medicine that uses that approach. But in general, prostate cancer, breast cancers, they haven't seen as much of a strong response using immune checkpoint inhibitors as we have in other types of cancer like melanoma and lung.
And then one last question I see here is there a research study that you're aware of right now that one could be involved in regarding ER positive and HER2 positive immunotherapies?
Yeah, so there's, I think there's certainly studies ongoing. There's other types of immunotherapies that we haven't talked about. And so, there's studies where we can modify immune cells to specifically go after HER2 positive cancer cells. And so there are studies in that space, immunotherapy studies in that space, because that's an area where we feel there's a great need for new and different immunotherapies.
Okay, I believe that gets us to the end of the questions we have received. If there are any last minute questions, we could take maybe just one or two more before we wrap up today. Standing by. I don't see anyone typing as of yet. So, Dr. Chan, I think we can wrap up. Oh, sorry, I did get two more. The side effects of immunotherapies, can you go back over that piece? Is it anticipated that the side effects would be less for an individual on an immunotherapy treatment than a chemotherapy treatment?
Yeah, I would say it's different. So it could be less. I think but it's just different. I think less or more it would be a little misleading. I think it's a different type of side effect profile. I think we mentioned a little bit about how they could sometimes mirror autoimmune conditions. But I think I've seen patients have minimal side effects on immunotherapy. Like I had a 92-year-old who was treated, who had renal cell carcinoma, who was treated with immunotherapy, and he was a park ranger, and he continued to walk like a mile a day, on the trails next to his house. So, I think it's just a different side effect profile, and I think it's kind of individualized in terms of how people respond and how people to the immunotherapy and kind of the side effects they might experience.
Okay, and then our final question is a clarifier. Is Keytruda considered a targeted therapy or an immunotherapy?
It's considered an immunotherapy because its primary goal is to use the immune system to activate the immune system to target cancers.
All right. Well, thank you, Dr. Chan. You were on the hot seat for several questions, and I really appreciate you getting to all of those. You're also getting a lot of thanks in the chat for the presentation and the knowledge. We will send out a link afterward. We did get a couple of requests for that, so we'll make sure you receive the recording for those of you who would like it. So thank you again. We so appreciate you joining us to celebrate Survivors Month together, and we got such great information as a community, and look forward to seeing where immunotherapies take us in the future. Thanks, Dr. Chan.
Thank you so much. Really appreciate everything.